Our webinar today will discuss meningiomas, risk factors, treatment options, and future advances. My name is Jillian Demas, Senior Program Manager here at the American Brain Tumor Association, and I am delighted to introduce our speaker today, Ronald Warnick, MD. Ronald Warnick is the John M. Tu, Jr. Chair in Neurosurgical Oncology, Professor of Neurosurgery and Radiation Oncology, University of Cincinnati, Neurosurgeon, Mayfield Clinic, and Medical Director of the University of Cincinnati Brain Tumor Center. Thank you so much for joining us, Dr. Warnick, and you may now begin your presentation.
Thank you, Jillian, and welcome everyone. It is a great pleasure to be with you today and talk about meningiomas. I'm going to talk about several subtopics. First, the incidence of meningiomas, and something very important, risk factors. I'll talk about several classification schemes for meningiomas, presenting symptoms, most common in patients, and then how we image or how we take x-rays, the different types, different modalities. But I will spend the majority of my time talking about treatment options, including surgery, radiation, medical therapy, and I will touch on the end at some future advances that are very exciting. So first, about the origin of meningiomas. Meningiomas grow from the outermost protective layer of the brain, called the dura. So this is a cartoon of a patient looking at them straight ahead from their face side. Here is the bone, the skull. The dura is this protective layer that is outside the brain, just beneath the skull. And here's the meningioma arising from that dura and invaginating into the brain. Although called a brain tumor, it's really outside the brain. I was able to find an MRI scan that's very similar to the cartoon. This is a real patient. I will show a lot of MRI scans, so I just want to orient you. Always the right side will be here, and the left side will be here. The gray is the brain. Black are fluid spaces of the brain. And this is the meningioma growing from the dura, and you can see the dura right here, and invaginating into the brain. And then interestingly, this patient also has a mirror image, small meningioma on the other side. Meningiomas are common. They represent a little over a third of all primary brain tumors, that is, tumors that start in the brain. And approximately 21,000 patients will be diagnosed each year. They're much more common in women than men in a ratio of about 3 to 1, and we think that's because of hormonal influences. Now, the average age of a patient with a meningioma is 63 years, but as you can see in this graph looks at the incidence or the frequency of seeing meningiomas in each age group. So these are ages along here. You see the decades. And meningiomas are very uncommon in children, and they increase in the 20s, 30s, 40s, and increase pretty much exponentially all the way up to 75 years old. And again, more common in women than men. There are various risk factors that have been either proven or associated with meningiomas. This is the hot topic in neurosurgery and neuro-oncology. Definite risk factors are higher level radiation, such as in Israel, when children were immigrating in the 50s and 60s, they were treated with radiation to the scalp for an infection, tinea capitis, and 10, 20, 30 years later they developed meningiomas. So radiation, high level, therapeutic radiation, is a cause of meningioma, which is unusual and almost ironic because, as you will find out later or may already know, radiation is a treatment for meningioma. Now, there are some genetic disorders that cause meningiomas. The most common is neurofibromatosis type 2. This is a mutation that typically runs in families. It's on chromosome 22, and it leads to multiple meningiomas and also multiple acoustic neuromas. Biggest topics in discussion relate to possible risk factors. There's some association between lower level radiation, dental x-rays, and of course people always ask me about cell phones. This association is very weak and has not been proven. So low level radiation is a concern and I would limit it, but it's not been proven. Head trauma such as concussion or skull fracture has been linked in 1 or 2 studies, but probably not important. We know there's an association between meningioma and breast cancer. that breast cancer patients have a moderately higher risk of developing meningiomas later. This may be because both have estrogen and progesterone hormone receptors. One of the most intriguing associations is a negative association, that is allergies. So seasonal allergies, such as you might have hay fever and might need medication like Allegra, that has a protective effect in that if you look at a large population of patients, patients with allergies have a lower incidence of meningiomas and in fact of brain tumors in general. There are many classification schemes for meningiomas. One is by distribution or location. So I have here a cartoon also of the dura, and it turns out that 30% of the meningiomas arise from the dura that's on what we call the convexity, that is the dura that is outwardly facing. 27% arise from this midline piece of dura called the falx. But the largest percentage, 43%, arise from the dura that is along the skull base, so-called skull base meningiomas. Interestingly, about 8% of patients will have multiple meningiomas. So as we follow patients for their primary meningioma, we must also look throughout the scan to make sure that there's not a second meningioma. But we also classify meningiomas, very importantly, by pathology. And there are 3 grades. Grade 1 is considered benign. That's the most common. Grade 2 is atypical. And grade 3 is malignant. Here is a microscopic view. So this is what the pathologist looks at on the microscope after I remove the tumor of a benign meningioma. Each of these little purple dots represents a tumor cell. The pink is the background. And as you can see, there's large areas of pink, which means that there are not a lot of cells here. They're not tightly packed in, and the cells look relatively normal. They look benign. But look down here at a malignant meningioma. There's less pink background, many more cells, and many of the cells are very large and angry looking, and that is what makes up a malignant meningioma. So the pathologist can tell us the grade of the tumor, and that often dictates the kind of treatment that's necessary. One other classification is by genetics. I mentioned neurofibromatosis type 2 as a familial disorder, but it turns out if you take a group of patients who don't have NF2, who just have spontaneously occurring meningiomas, and you look to see and analyze those tumors for loss or mutation of this NF2 gene, about 50% of patients with just regular spontaneous meningiomas also have this genetic defect. Interestingly, a new study from last year has shown that you could predict the genetic defects that a meningioma has based on location. So for example, this is a skull looking from the top, and this orange area represents meningiomas in this region have mutations in these genes, and therefore location can determine gene defects and thus ultimately determine biologic therapies that might be given for those tumors. So this is cutting edge and soon will be used for treatment options. Presenting symptoms, most patients, or many patients, present without any symptoms. Their meningiomas picked up incidentally or accidentally. For example, they bump their head, have a CAT scan, it shows, and they don't have any symptoms. But if a patient with a meningioma has symptoms, the most common is headache. Seizure is also very common. Memory disturbance, cognitive problems, memory disturbance, personality, weakness on one side of the body or the other, speech problems, and then also sensation and vision less commonly. Sometimes patients will have an external sign of a meningioma. Here's a woman who is a nurse who noticed a gradually increasing bump on her head. And then over the past 3 months, the bump became very large very quickly. This is the patient at the time of surgery. When I operated on her, you can see that this is the normal level of the skull and scalp, and this is the bump. And here is her CAT scan. CAT scan is a little bit different than MRI. The skull is white, and this is all normal. Here's the brain. And this entire area is excess bone that formed because of the meningioma. And this is an important finding feature of meningioma, is that it causes the skull to overgrow itself. And sometimes that appears as a bump. So let's talk a bit about the kinds of x-rays that we use for patients with meningiomas. One of the older type of x-rays that's still very useful is a CAT scan or CT scan. It's very useful because many meningiomas have calcium within it. You saw the first patient, but here's another patient, and here's a meningioma that actually is rock hard. It's literally a rock. And that's because of calcium, just like the skull, and a CAT scan is ideal for showing that. That's important, and your doctor may ask for a CAT scan because he wants to know ahead of time how easy or difficult it's going to be, because calcium sometimes makes the tumor more difficult to remove. But by far the most common type of imaging study done is an MRI scan, and that's because it shows the brain in better detail, but also we can get 3 dimensions. So here's one dimension, one view of the patient from the side, which this is the eye, this is the forehead, this is the top of the head, this is the brain, and this is a very large meningioma. So we're looking at the patient from the side. This is in what's called the temporal region. This is a view where we take a slice of MRI across the patient, and we have a different view. And this is the view that I've already shown you, which is the view from the patient from the front. And again, this tumor that's both inside the skull and actually has eroded outside the skull. The features that we look at to determine if a particular tumor is a meningioma, the first is its location. I mentioned that the dura, which is right under the skull, here's the skull, the dura is right here. The tumor is arising from that and invaginating, pushing into the brain. But actually you can see this little line of fluid that still remains. It's protecting the brain from the tumor. So these tumors are inside the skull but outside the brain. They also light up with the intravenous dye that's called gadolinium. Many of you have had that test. The gadolinium is important because here is the meningioma before gadolinium. I can see it, you can see it, but look how much better we can see it when we've given the gadolinium dye. So that's very important. It also shows this feature, dural tail, a little tail of tumor that's extended along the dura in 2 directions. That's important for the surgeon to know about because that should be removed at the time of surgery to prevent regrowth. We also sometimes, particularly in malignant meningiomas, see brain edema. This is a malignant meningioma. You see it's not round like the others I've shown you. It's a little lumpy, bumpy. It's invading the brain. And all of this is swelling, or what we call edema of the brain. And here's a different view of that. Here's the tumor shown a little bit differently, and very dramatically the swelling. So it's a combination of the tumor plus the swelling that leads to increased pressure of the brain and the headaches and other symptoms patients experience. Here's a very important one. Meningiomas have a rich blood supply. They have the ability to tell the brain to produce more blood vessels, to bring more nutrients into it. This is the tumor here on an MRI. And every one of these black dots represents a large blood vessel within the tumor. This is a different test called a CAT scan angiogram, where we're injecting dye into the blood vessels. These are the normal blood vessels. Everything's normal. This is a normal blood vessel, but right next to the normal blood vessel and feeding the tumor are it's a bird's nest of blood vessels here. So it's a very bloody tumor. The surgeon absolutely needs to know that to prepare for blood loss. Luckily, we have a procedure that can block those abnormal blood vessels to the tumor and make the surgery easier. So this is what's called an angiogram, where one of our specialists puts a catheter up into the artery and injects dye. The black represents the dye going up. And each one of these is an abnormal blood vessel, very enlarged, feeding this bird's nest of blood vessels, which represents the tumor. The specialist can then inject a special glue into these blood vessels and block them off. And here's the result. All the normal blood vessels remain, and here was the meningioma that used to have blood vessels, and now these little lines represent the glue that has blocked off the blood vessels. This is very helpful to the surgeon, and we do that within a few days of the procedure. So we've talked about imaging, and we now have a patient such as yourself, who has a meningioma, and we need to talk about treatment options. And they are broken down into observation, surgery, radiation, and medical therapy. Observation is very appropriate for patients who don't have any symptoms, where it's picked up incidentally, or a patient has migraine headaches and they're found to have a meningioma. Therefore, smaller tumors. We usually get regular MRI scans every 6 to 12 months in the beginning, and then we follow at longer intervals, probably 2 years and 3 years, and we follow for 10 or 20 years. Here's the natural history of meningiomas. If you follow all these small meningiomas, there'll be no change in the growth of the tumor in 70% of those patients, but there will be tumor growth in about 30%. And here are some examples of patients who I've recommended observation and they're still being followed. A convexity meningioma, another convexity meningioma, and here's a skull base meningioma. So observation is appropriate, but sometimes it's difficult to persuade a patient that, for example, their migraine headaches are not related to the small meningioma, and that's understandable. So what about surgery? What would be the goals for surgery, or the rationale for surgery? Well, the most important goal is pathology. It confirms the diagnosis that it's a meningioma and also tells us the grade of the tumor. Remember, I mentioned there are 3 grades. We would then know for sure the grade of the tumor. We can also do hormone receptors. We can look at other special markers that we call biologic markers that may predict the growth and recurrence of the tumor. So it's always better to have a pathology than not. Also neurologic. Some patients come in with very large tumors with swelling, like the patient I showed you with the swelling of the brain, with pressure effects and neurologic symptoms. We know that surgery is the fastest and best way to improve somebody's neurologic condition. It also, we might remove a tumor that we think will grow soon and cause a neurologic problem because we want to do it preventative. But also, from an outcome point of view, if we have a grade 1 benign meningioma and we completely remove it, that's curative in over 90% of patients. So that's a reason in and of itself to do surgery. But there are many factors that we consider and that I discuss with the patient, and they are split into 3 categories. Factors that relate to the tumor, the patient, or the surgeon. From the tumor point of view, many things that I've mentioned already, like the location of the tumor, size and brain swelling, does it invade the brain, or what grade it is. So those are things that I tell the patient about. But the patient has the final decision, and there are important things for them to consider. Their age. The older you are, the less likely you can undergo surgery. If your neurologic status is affected by the tumor, then more likely to have surgery. But ultimately, it's the patient's choice after hearing all this information. But let's not forget about the surgeon. There are important factors related to the surgeon who you see. Their ability and their experience. For example, early in a career, the surgeon may be a little tentative to take on a big, complex meningioma, whereas another center or more experienced surgeon, even at that own center, may wish to undertake that surgery. And also the resources of that particular hospital in terms of the complex surgery. So we take all of this together. I make a recommendation, but normally I give options and the patient makes the decision. One thing we do prior to surgery that's very important and new in the past 5 years is we do a functional roadmap for the surgeon. So our special neuroradiologists perform what's called a functional MRI, where they map out the important eloquent or sensitive areas of the brain. So here's one of these maps. Here is a picture of the brain from the top, the left and the right, and look at the size of this meningioma. And what they've done at the time of surgery is they asked the patient to tap their fingers together, and they looked at and mapped out the area of the brain that's activated, and they had them tap their foot, and they mapped out exactly where that place was. So now I had an exact location, an idea where these were, and I counseled the patient that they would likely have some temporary hand weakness after surgery, but that their leg would probably be fine. And that's what happened, and ultimately the patient recovered. But you need to know where those important areas are. Now, all of this surgery is done computer guided. That doesn't mean the surgeon's not involved. No, the surgeon's primary, but the computer is used as a tool. What we do is we do an MRI scan with these little markers. Think of them as little lifesavers, plastic lifesavers that go over the forehead and behind each ear. Then we do a CAT scan or an MRI scan with the markers, and here's one of those markers, and here's the meningioma. We feed that into this computer workstation in the operating room, and then we can see everything in 3 dimensions. And there's a camera system that sends out infrared light that then tracks this instrument, which is a pointer, so that after we calibrate, here are those markers, we calibrate or touch each of these areas to let the computer know where the patient is in space. And then we can take that pointer and put it right over where we think the tumor is. We can then look on the screen and see, yes, we're directly over it, or no, we need to move 1 centimeter or ½ an inch forward. So we can plan the operation and make a relatively small incision compared to before where we have to make large openings. This has revolutionized brain tumor surgery in general and specifically meningioma surgery. Some of you have already had a craniotomy, but for those who are interested, I wanted to show you a schematic of what an actual meningioma operation would entail. Here's the patient under general anesthesia, held in place with this Mayfield 3-pin head holder. That's important, that they don't move. And we're going to make the incision. And here's the edge of the skin with little clips on it. That's to prevent bleeding. The skull is here, and this is muscle. We're going to make an opening in the muscle for this particular tumor. And now we've opened the skull and taken the bone flap out and placed it in antibiotic solution. And here's the dura from which the meningioma arises. It's a very shiny structure. And this is what it would look like. Here's the brain, and here are blood vessels, an artery in red, a vein in blue. And this is the dura from which the meningioma would arise. And then we close everything back up with little titanium plates. So here's an actual patient who I operated on, and I'm going to show their operation, not a video, but just a few pictures. It's a 59-year-old woman with a long history of migraine headaches, but her headaches changed in frequency and severity, which prompted an MRI scan. On my examination, she was completely normal. Here's her meningioma. It seems pretty large. It's convexity arising from the external surface and pushing into the brain. There's another feature here that you may not note, but it's involving the bone, going through the bone. So I knew that prior to surgery. So here's a picture at the time of surgery. Here are those clips on the skin. We've already opened the skin, so it's already open. This is the skull. We've removed the skull in this region, and you're looking at the dura, that shiny structure. And the first thing you see is that the tumor is actually eroding through the dura. That's unusual, but in this case, we knew that would be the case. And here's the skull from the inside, looking at it. This is the tumor that actually is growing into the bone. So we have to remove that and remove the bone in this region, and then we have to open the dura and take out this tumor. So now we've opened the dura. The dura has been opened here, and here's the brain, and there's a vein, and this is the meningioma. It often has this color, kind of orangish color, and it's stuck deep into the brain, about 2 inches deep. So we dissect around it very carefully using the microscope. Sometimes we core out the center of it to make it easier. And here it is after the removal. This is the tumor cavity. It's a little hard to tell that this is about 2.5 inches deep, but this is what the brain that was pushed away. It looks pretty good, maybe a little blanched in this region from the pressure. So a successful operation. It was a benign meningioma, and she's been doing well. And here's what it looked like. This is the part that was in the brain, this meningioma, and here is the remaining dura around it. Now, surgery has some limitations. Sometimes blood vessels, arteries or veins are in the way, and we cannot remove the tumor completely, or it puts the patient at risk. Also, eloquent areas. We think of the brain as being all very eloquent and sensitive, but there are some areas that are even more important. We call those eloquent, such as the optic nerve for vision, the cranial nerves for moving your eyes or moving your tongue, and the motor, sensory, language, and vision. So sometimes if the tumor is involving an eloquent area, we may not be able to remove it completely. Also, very problematic for us are highly invasive or multiple meningiomas that might not be amenable to surgery. So here are some examples of our limitations. Here's this massive meningioma with very important blood vessels here and here. We're not able to completely remove that tumor because of those blood vessels, trying to preserve them. Here is where on this MRI, looking at the patient straight ahead, there's a major vein here called the superior sagittal sinus. We must protect that, so we may remove most of the tumor and leave some right along the vein. This is a patient who was unfortunate in that the meningioma was on both sides and it was invading the motor area on both sides. And we did obtain a complete removal. She did have some weakness for a period of time, but ultimately improved. And lastly, this is a patient who we did not operate on because look at the diffuse nature of the meningioma over the surface of the brain, down the center of the brain, and even a lump here in the brain, not suitable for surgery. It's important to mention the risks of surgery. They're split up into 3 categories: neurologic, regional, and general. The neurologic ones relate to the function of the brains, so bleeding or brain swelling or seizures can be a complication of the surgery, or stroke even if a blood vessel is injured. We have regional complications such as the wound, infection, or wound breakdown, about 1%. And then of course anybody undergoing surgery could have a complication from anesthesia, from the heart or the lungs, or a urine infection. And one thing I'd like to point out is the high incidence of blood clots in the legs in patients with meningioma who undergo surgery. We always have to be cognizant of that and prevent them. Now, I'd like to switch gears a moment and talk about radiation, because sometimes meningioma cannot be removed or not be completely removed, and we need to consider radiation. First, the energy levels of radiation. They go from low, such as radio or microwave, intermediate, such as the ultraviolet from the sun, but the meningioma radiation for patients with meningioma over in this side, very high dose radiation, either X-rays or gamma knife. So it's important to note that we're on this side of the spectrum. And the reason is that the target for radiation is tumor DNA. So let's look at the tumor cell. Here it is, and within it are chromosomes, these little X's. And here's an example of a chromosome. And if you unravel the chromosome, you get DNA. And here's this helix. And within that is a gene. And within the gene are these little bonds. And the target are these bonds. And you'll see that in a minute. So radiation is delivering energy to the tumor cell DNA and causing damage. So here's how it works. The radiation beam comes in. It hits a drop of water that's within the region of the tumor cell. And that causes the water to kind of agitate and send off what's called a free radical, which think of it as a tiny firecracker, which hits the DNA and causes a break in the DNA. And that's the basis of radiation. Now, if it were just that, then you could imagine that it might do that to the tumor, it might do that to the normal brain, and that could be a problem. Well, in fact, occasionally a brain cell will receive some radiation and there will be a break. Of course, the tumor cell did get a break, but there's a big difference between the normal brain and the tumor, and that difference relates to repair. The normal brain is able to repair itself in a 24-hour period, whereas the tumor cell cannot. So as we give additional doses of radiation, the normal brain constantly repairs itself quickly, the tumor cell unable to, and accumulates significant damage, which leads to the death of that tumor cell. And imagine that magnified millions of times over throughout the tumor. There are many common radiation machines. You may have heard of these or been actually treated on them. The TrueBeam, which is a linear accelerator, that is X-rays. The Novalis, which is another form of linear accelerator, X-rays. CyberKnife is somewhat intriguing because it's a robot. This is actually a robot like they might have at an auto assembly plant. and it targets the tumor, and it's also a small linear accelerator. And then Gamma Knife works a little bit differently. It's gamma radiation. There are more similarities between these machines than differences. They all can accomplish meningioma radiation. But I would like to mention two terms that are very important. Your doctor may speak of these. One is called radiosurgery, and the other is radiotherapy. Now, the term radiosurgery is really a misnomer. It doesn't involve surgery at all. It's high-dose radiation, 1 to 5 sessions, typically 1, and a very tight treatment area. So here's a schematic showing the tumor in green and showing the areas of radiation tightly wrapped around here. I like to think of it as shrink wrapping the tumor with radiation. So a very tight beam, typically 1 dose. Radiotherapy, though, is multiple low doses, each day getting a low dose, anywhere between 6 and 33 sessions, although for meningiomas it's typically 28 to 33. And there's a larger margin of brain. And so here's an example. And this is the kind of treatment, so the radiation you see is broader than over here. This is the kind of treatment, radiotherapy, that we would give to a patient who had a malignant meningioma. And this is the kind of treatment we would give for a patient who had a small benign meningioma. And there are many indications for radiation. An inoperable meningioma, it's eloquent, important area we cannot operate, or the age of the patient. After surgery, where the surgeon has incompletely removed the meningioma. After surgery for all malignant meningiomas, I want to emphasize that a patient with a grade 3 malignant meningioma absolutely needs radiation, no matter how good the surgery is. Also, for recurrent meningiomas, after previous surgery, so I had surgery 10 years ago, it grew back. Radiation is used when there are many medical problems for the patient that preclude surgery. And the most common one, and increasingly common, is patient choice. Patients are choosing radiation over surgery for small to medium-sized meningiomas because of the non-invasive nature of radiation. Here are a couple examples of meningiomas. This is involving the cavernous sinus. It's not operable, but very good for radiation. This is a very, very diffuse tumor. This is only one image, but imagine the entire left side of the brain is coated with this meningioma, not suitable for surgery, but definitely suitable for radiation. And both of these would be the radiotherapy, the 28 to 33 fractions or days. Here's an example of a patient who underwent partial removal. Here's the meningioma. Again, this is on the left side. And the surgeon was able to remove part of it, but this part remained, and this part remained. This is just some blood. So we need to go do radiation to treat this portion of the tumor also. And I showed you this patient already with a malignant meningioma. Complete removal of this tumor by the surgeon, we still need to give radiation therapy. And here's an example of a patient who, in 2003, a little bit before this, underwent removal of a very large meningioma, and there was a small remnant left. This was treated with radiosurgery, small, very focused dose over 1 day, and then it started growing back 2 years later. She was lost to follow-up. She moved, didn't have a neurosurgeon, came back to see us 2014. The tumor is large again. So she's now elderly and cannot undergo surgery, so she's being treated with the fractionated radiotherapy. And 2 patients who I gave them a choice between surgery and radiation, and they chose radiation. Both of these were radiosurgery, 1 to 5 doses. What are the results? They're great. 90% probability that the meningioma will not grow during radiation or because of radiation, and that's a 10-year result. So follow patient for 10 years, 90% chance of a good result. But I like to think of this as a rule of threes. If you follow patients over time, 30% of patients will have no change in the size of the tumor at any point. That is, it's stable, not growing, but hasn't shrunk. 30% will have minor shrinkage. That is, the doctor has to actually make measurements to be able to define the shrinkage. And 30% chance of major shrinkage. Patient looking at the scan could see the difference. One thing radiation may not do is reverse neurological symptoms. So for example, if a patient comes in with blindness or with severe visual disturbance, radiation may not reverse that. Only surgery can. There are some side effects of radiation. The first is fatigue, which normally would occur with the fractionated radiation, the many weeks of radiation, but could occur even with 1 to 5 fractions. And then also hair loss at the site of the treatment, which is usually temporary at the doses that we're using here. And then scar tissue, something called radiation necrosis. Here is a patient who had this meningioma treated with radiation. And look at this white area here. This is all swelling and scar tissue that developed as the result of the radiosurgery. About 6 to 18 months later is the peak time period for that radiation necrosis. It can be treated with steroids and other therapies and usually responds. Another thing that can happen with radiation, believe it or not, is a new meningioma can form. This is a young woman who had treatment for meningioma several decades ago, and then she now has in the field of radiation a new meningioma, separate from the previous site. So I mentioned that meningiomas, the risk factor is radiation, so it's used to treat, but it also very rarely, and the risk of that is probably 1 in 100,000 chance. The last therapy that we work with and we offer are medical therapies. And these are either medications or injections that we use. And the indications for them are if a meningioma has grown after previous surgery or radiation, then we're left with only one option, and that could be medical therapy. Patients with multiple meningiomas, and then also patients with very diffuse, that is, over the entire surface of the brain. Here's an example of a patient who actually is a very current patient because I'm discussing treatment with her. She was the one that had that very large bump on her head. This was all bone, and this is the meningioma. We took that out and we gave radiation because it was a grade 2 tumor and we weren't certain we had removed it all because it was infiltrating the bone. She did well for 3 years. It's a little hard to see, but this white area right here represents regrowth. So I did surgery again and removed that. Unfortunately now, just this past week, she has regrowth of the tumor in a different area. Unfortunately, this area has already received maximal radiation. Surgery is not possible because it's over a very broad area. Other images show that. And so we're talking to her about medical therapy. Here's a patient with multiple meningiomas. This is a patient with neurofibromatosis type 2, and you can see how many meningiomas there are. Either radiation or medical therapy would be needed. And I mentioned before the diffuse meningioma, where it's over a large surface of the brain. You see it there. And then this patient, the entire dura, all the way around, is involved with meningioma. We're hesitant to give radiation to the entire brain, and so medical therapy may be appropriate. There are 3 approved medical therapies for meningiomas. The first is hydroxyurea, also called Hydrea, and this is a capsule. And what it does is it tricks the meningioma into dying, the actual meningioma cells. They go down a certain pathway. It's a normal death pathway, but they accelerate the tumor cell death. It's had some effectiveness in about 20 to 30% of patients. Also, alpha interferon, called Intron, is an injection, and it inhibits those blood vessels that I mentioned, lead to a kind of a bird's nest of blood vessels. And by starving the tumor of blood, it can reduce this tumor size. And the third treatment is sandostatin. The brand name is, you may hear, is called octreotide. There's actually a nuclear medicine scan that can be done with octreotide that can show whether your meningioma lights up with this, and thus you might be a candidate for sandostatin. This is an injection, and it works through hormone receptors. So we have relatively few approved medical therapies. But help is on its way. because there are many scientists and physicians who are working on new advances and future advances. In preparation for this presentation, I looked up on clinicaltrials.gov and found that there were 18 active clinical trials. Most of them involved the standard agents, hydroxyurea, interferon, and sandostatin, combined with another drug, hoping that 2 is better than 1. But many of them were what we call biologic agents. If you look at this cartoon, you'll see that this is supposed to be the outer part of the meningioma cell, and there's this what's called a receptor, which I like to think of as an on-off switch. So somehow some factors come in, they lock in, and they turn this on, which leads to revving up of this mechanism here, which leads to growth and even blood vessel formation. So many agents can block different points in this cascade, such as Avastin, or this drug called everolimus, or Sutent, and there are many more that are being tested right now in patients in clinical trials. A quite different treatment that's going to be in clinical trial is called Novo TTF, named after the company. These are electrodes that are basically pasted to the patient's head. Here they are. There's an adhesive tape that tapes it in the area of the tumor. The patient then carries this battery pack in a small backpack. And what this does is it sends alternating electrical currents which disrupt or inhibit tumor cell division. It's been used and proven in tumors called gliomas, and now it's being tested in meningiomas. But it is best for tumors that are rapidly growing, so it's probably going to be of greater benefit for patients with high-grade meningiomas. So more on this later, but this is very exciting because it doesn't involve any injections, just wearing this device, and obviously the patient can wear a hat or a scarf. So I think what you can see from this example and the clinical trials that there are some really exciting new therapies on the horizon, and we think these will offer new hope for meningioma patients. And at this point, I'm going to turn that concludes my presentation. I'm going to turn it back over to Jillian because I know that there are a lot of questions. I'm going to try to answer as many as possible. And I really want to thank each of you for being here today, your attention and your time to listen to this presentation. Thank you very much.
Thank you so much, Dr. Warnick. And you are correct. There are a lot of questions, and we did have a wonderful turnout online. So we're going to get right to the questions. One that I'm going to be a little selfish that we hear a lot of is the personality changes. So I'm going to start out with that one. And I don't know how much you can answer about that and how much you see in your practice of, after surgery, do you see a lot of meningioma patients that then have the personality changes, the paranoia, and the memory changes, and how do you help the families cope with that? Do you see much of that?
Well, we see it even at diagnosis because meningiomas, particularly in the frontal lobe, base of the frontal lobe, can cause personality change and trouble with executive function and even depression. So we have some patients who come to us from the psychiatric ward and they have a giant meningioma. So they're a little bit different. Yes, many of my patients do complain of those symptoms, typically based on where the tumor is located. I think one of the most important things is if there are memory problems or cognitive problems, that the patient should see a neuropsychiatrist. Now, you hear the term psychiatrist and you say, okay, well, that doesn't sound like it's for me, but a neuropsychiatrist or a neuropsychologist, maybe a little bit more common, they're the ones that do the in-depth memory testing and cognitive testing. They may help you find some strategies to improve memory. And I found them very, very useful. So you could ask your doctor, your neurosurgeon, to refer you to a neuropsychologist. They also, both the psychologist and psychiatrist who specialize in this, do work with patients who are having unusual feelings, abnormal feelings, such as paranoia, and I think they've been very helpful for those patients. And I don't mean with drugs, I mean with discussion. and with counseling. So I encourage a referral to neuropsychology.
Wonderful. There's a couple questions about hereditary. Are meningiomas a hereditary diagnosis?
Typically not outside of syndromes such as neurofibromatosis type 2. Having said that, there are some families. I have a father-son combination right now who luckily they're doing very well, but you're not going to believe this story. They were both admitted to the hospital at the same time for meningioma surgery. One was elective in that I had planned to remove the meningioma, and then his son was having some symptoms, and we admitted him with the meningioma in a different location of the brain. So there must be something going on there, but we haven't defined it. But as mentioned, many scientists are analyzing the meningiomas after they're removed and looking for a genetic defect that might link patient, family members who both have meningiomas. But if a patient is asking, will my brother or sister or daughter have an increased risk of meningioma, typically I would answer no.
Okay, and as a follow-up question, a mother was asking if their child should get MRIs at an early age.
Very good question, because that's really what's being asked of every tumor, every lesion in the brain is, should my family member be tested, and if so, how often? And that's one of the biggest concerns and biggest questions. I would say in general, no, I wouldn't do a screening MRI, but if I saw a cluster of patients within a family with meningioma, then I would. And then the next question is, if you have one and it's normal, when do you do the next one? Or do you do the next one? Do you wait a year, 5 years, 10 years? So a lot of questions involved with this, but I would limit it to families that have a cluster, 2 or more patients with meningiomas.
Perfect. Any suggestions, again, a couple questions on alternative and complementary therapies for meningiomas?
Well, I will say that I'm a firm believer in combining complementary therapies with traditional therapies as long as both sets of doctors, maybe there's sometimes different doctors involved, know what the other is doing. I'm not an expert in complementary medicine. However, I will say that it's very important in general, if we look at diet and activity and how it affects tumor formation and growth just in general in tumors and cancer, that a diet that's very high in antioxidants, that is fruits and vegetables, is favorable for a patient to reduce their risk, and that you want to reduce things like cured meats, so bacon and salami and pepperoni. And then if you're smoking, you want to stop smoking, and you want to increase your activity, because almost all cancers relate to activity, not meningioma per se, but these are some things you can do to stay healthy, but also potentially reduce your risk of growth or risk of recurrence.
Perfect. Can anyone be on watch and wait or watchful waiting for their whole life?
Oh, many patients are. I'm following many hundreds of patients who are, and now that I've been in practice for 24 years, I follow them since the beginning, and they're stable. Yes, that's very common and is often the case when somebody comes with an incidental meningioma. I've also had situations where their tumor was growing, we scheduled surgery, for some reason the patient decided not to have surgery, and 10 years later they're okay. So they obviously knew better than me that surgery was not needed and their tumor was stable forever. So yes, it happens very commonly.
That's great news. Let's see, flipping around here, can you tell us anything about MRI-focused ultrasounds for meningiomas?
Oh, fascinating question, because this is being examined in many areas of neurosurgery and brain tumor field. Think of focused ultrasound therapy as being very similar to radiosurgery that I mentioned, which is 1 to 5 doses of radiation to a very tight area, basically shrink wrapping the tumor with radiation. Focused ultrasound uses something similar to, almost looks like a gamma knife, to focus these beams of ultrasound to the point of the tumor, like an intersecting fashion. So all these beams are hitting the tumor, and when they collide at the tumor, they lead to death of the tumor cell. They disrupt the DNA in a similar fashion to radiation, but without the risk of radiation-induced secondary tumors. So this is very cutting edge, and I'm sure there'll be more on this. And next time I give this presentation in a few years, I bet that I'll be including that.
That would be exciting. We'll sign you up. Is there, sorry, lost my train of thought. Risk in the, we'll try one more time here. Discuss the risk of radiation necrosis a little bit further. Someone wasn't quite understanding. I know that slide showed it was pretty impressive on that slide, but what can that do to a person? What are the implications?
Okay. I'm happy to expand upon that. Let me talk about that particular patient because I think it's important to form a concept around a patient. That patient was doing well until about 6 months after radiosurgery, and she started developing unsteady gait, headache, nausea, vomiting. We got that scan showing the massive swelling. It was a very scary looking MRI. It looked like something that might require surgery, but we placed her on steroid medication. She promptly improved, and then we gradually followed her over time. I tried to take her off of steroids. That didn't work. She went back on. And I started a drug or simple medications called Trentol, which is a medication for another purpose, but it's used to treat this radiation effect, plus vitamin E, which is an antioxidant, and this improved her condition, and the brain is calming down. So the first thing to note is that it's a delayed phenomenon, 6 to 18 months later. Why? Well, there are all kinds of possible reasons, but it just is surprising that it doesn't happen right after radiation, but at a delayed fashion. It can devastate the patient really because of the swelling if it's not under control. But the good news is usually tincture of time is all that's necessary to resolve it. And now we have a new drug, though, also called Avastin, which I mentioned is a tumor fighter, but it's also used to treat radiation necrosis. So it can be a problem, and it occurs about 3% of the time after radiosurgery, almost never after radiotherapy, and about 1% of the time would be something where we have to give a drug like Avastin.
Perfect. You mentioned the connection with breast cancers and hormones. What is the role of hormones that are naturally occurring and the role of hormones that are commercially that you would take, for instance, as the contraceptive pill or HRT? How do they affect meningiomas differently?
Well, it used to be thought that meningiomas had frequently had estrogen receptors, and really estrogen receptors are very rare on meningiomas. Of course, they're not rare on breast cancer. And they occur really in like 15% of meningiomas. If you look at their hormone receptors, will have estrogen receptors. But if you look at progesterone, about 35% of meningiomas will have progesterone receptors. In fact, there was a therapy called RU486, which was used to block those progesterone receptors, and the study did not work. The drug was not effective because so few meningiomas have the progesterone receptors. So I would say that estrogen is not as important here, whether external, as in pills that you take, or, as you know, the BPA from that chemical from old water bottles has estrogen side effect, has estrogen effect. That's probably not going to make a meningioma grow, but it's more on the progesterone side. So what I tell my patients, if you're going to go on progesterone, then, and your scan is, let's say, scheduled for 2 years from now, we need to do it sooner, like 3 months later or 6 months later, to make sure you're not having tumor growth from progesterone. So that's the important hormone.
You do they know what causes certain growth spurts in a meningioma? If, from scan to scan it's normal, and then all of a sudden there's a large growth spurt, is there a known cause for those?
Generally, no. But let me tell you one situation where that occurs where we understand it. And that is, if we see a patient with a kind of a typical benign grade 1 appearing meningioma, we don't know for sure because we haven't operated, but it looks very classic for that. And then we follow the patient, and on the next scan it grows dramatically. Well, then we know that it probably wasn't a grade 1, and when you do surgery you find out it was a grade 2. So sometimes a grade 2 will masquerade itself and show growth very rapidly. But if we take a different scenario where I'm following a patient for 10 years, everything is going well, and all of a sudden it starts growing. Our criteria for growth in terms of concern is if it grows 2 millimeters per year times 2 years, so total 4 millimeters, that's when we kind of wake up a bit and say, okay, we may need to do treatment. What causes that to be plateau and then grow again? We don't know. I wish we knew, because I think the follow-up question is, what can you do to prevent that? And I don't know of anything that a patient can do that could keep that risk low.
Great. I'm going to sneak in one more question, and my closing comments might run us over 3 o'clock, but I'd rather have one more question in, and then people can sign off. Someone is asking, what can cause a brain bleed after meningioma surgery?
Well, obviously that's a very tragic thing that can occur, and there are many possibilities. It could be as simple as a small bit of oozing from the brain surface that the surgeon felt was very well under control, and later it bled a little bit, and you see on the post-op CAT scan some blood within the cavity, but not causing a problem. So that's fairly common. But probably the biggest cause of a big bleed would be a vein injury. Those veins are very important because they take blood from the brain back to the heart. So if a vein is damaged during meningioma surgery, it leads to the buildup of blood within the brain, which shows up as a bleed. And that can be a devastating thing, but the good news is that's almost always reversible. So unlike the normal stroke you think of, this vein stroke, usually patients can recover with rehab.
Well, that's good news then. All right, that is definitely all the questions that we have time for. It is the top of the hour, and I appreciate you going straight to 3 o'clock. I'm sorry we couldn't get to everyone's questions. If you only knew how many were here. It was such a popular webinar, much needed, and we're already having people pop up saying thank you. So I can't thank you enough. I'm passing it along from all the members. So I'm going to pause for just a moment, and we are going to conclude our webinar recording, and then I will be back for just a moment to make some announcements.